The first Sustainable Action Panel will be talking about leveraging training and technology to support and sustain the home care workforce. We have three great presenters. Sharon Brundle, Director of Corporate Training for the Training and Workforce of Holyoke and Springfield Technical Community Colleges. Christy Johnston, Vice President of Governmental and Managed Care Services for Premier Home Care. And Helen Addison, co-founder and CEO of Care Academy. We've asked them to talk about how they have leveraged technology in the training and support of their home care workforce, what challenges they've encountered along the way, and what they see as the future of using technology to support that workforce. So I'll turn it over to Sharon.
Good morning, everybody. Sharon Brundle with Training and Workforce Options. Let me just explain that real briefly. Training and Workforce Options is a unique collaboration between two community colleges, Springfield Technical and Holyoke Community College, which share staff for the purpose of working specifically with employers in the area in different industries, so that we may be able to understand what the needs are, the workforce gaps, and provide any sort of customized training in that way. So we do quite a bit of training in the healthcare field, lots of other fields too, but I cover healthcare, nonprofits, government, municipalities, that sort of thing. So this morning, what I'd like to talk about is a story that started in 2015. It was a terrific match that was made between Holly Chafee, who is now the president and CEO of VNA Care Network here in Worcester. Holly, at that time, was the executive director of Porchlight VNA Home Care. We met while she was doing a tour through the simulation center at Springfield Tech Community College, and was pretty much in awe. And I was, staffed there and working in healthcare. And from across the room, we sort of noticed each other and said, hey, I think we can work together. And before you knew it, we had established a partnership with O'Connell Care at Home and sat down a few times and talked a little bit about what some of the issues were in home care. And I'm sure that they're familiar to you: recruitment, retention, really hanging on to people, and the proper amount of training that they really needed. So we decided that we would apply for funding through the Workforce Competitive Trust Fund through Commonwealth Corporation as a partnership, and would be redesigning the home health aid curriculum that we had in place. The discussion that ensued was, we need to figure out how to keep people out of the hospital. If we could do that, we would be really golden. So some of the efforts that we did to do that were that the employer said to me, in an effort to do that, I think that the home care aides really need to understand more about chronic care illnesses. I'm going to refer to the course descriptions that you have in your packet. This is what the curriculum was composed of. It was 80 hours in its entirety. And we decided on a few courses that needed to be developed especially for this group, and one of them was chronic care management. The illnesses that were described were diabetes 2, COPD, congestive heart failure. That was followed up with two additional conditions: skin integrity and urinary tract infections, just because they were very easy to overlook. And by designing curriculum that the home care, the direct care workers would understand, so that they could recognize symptoms that would be most common, and then they could alert a nurse, or they could take the appropriate action short of, anything that was out of their scope of work. That was very successful. Probably the most important thing that we did was to open up the simulation lab. Both Holyoke Community College and Springfield Technical Community College have simulation labs. We, at that time, were at Springfield Technical Community College. Their simulation lab is really a simulation hospital. There are 64 high-fidelity patients. They get up and they don't get up. They do everything but get up and move around. But they smell, they bleed, they do everything that is imaginable. So the first experience that we had was really in simulation with the aides, so that they could get some idea about what it was like to have some hands-on care, and without killing anybody in the process. So we had an entire, day scheduled where they were learning about universal precautions and wipes and how to approach their clients and whatnot. a number of other things came to mind. It wasn't just the technical skills that they needed, but these really essential skills. The essential skills that often are known as soft skills. It was really important that we taught them about professionalism. What does it look like in healthcare? How do you approach somebody who has a different cultural background than yourself? What do you know about their values, their practices, how families intervene in the process? These were all very much new to this group of people. And they got a lot out of it. Our goal in putting this program was to really increase the number of credentialed direct care workers, to align the coursework that we have to agreed upon core competencies that were developed through the ABCs of direct care workers. That was the PCAS program. Leanne Winchester is here. The Personal Home Care Aid State Training Initiative, where 13 core competencies were really laid out. And these were the things that we incorporated into it. We had core competencies, and then we supplemented everything with that, including the hands-on experience twice in the simulation lab. And then the third thing was to create new stackable credentials that met both those technical and essential industry standard skills. What I'd like to do is to show you just a 2-minute slideshow, give you some images of what it was like to work with this. We did 7 cohorts with this partnership of 2 employers over a period of a couple of years. There was WCTF funding, and then we tapped into the Workforce Training Fund to do a number of other cohorts with this. So let me tell you about the outcomes. Okay, we ran 7 cohorts. There were about 15 per class, a little bit of attrition here and there, about 100 people. We trained in a little bit less than 2 years. They came out with multiple certificates that could be stacked together: CPR, BLS, first aid, supportive aid Alzheimer's. This is the 12-hour course that is put together and that was taught. And the other courses that are part of this curriculum can be standalone courses for CNAs, home health aides, direct care workers, that sort of thing. Furthermore, we developed on the back of that page, for the second portion of the training, we developed a preceptor course for CNAs who were already experienced on the job, were great employees, and would make great role models for some of those newer CNAs. One thing I should mention is that the people who were trained were promoted from within. So if we had personal care attendants, PCAs, who were really pretty much hands-off, or home care makers, they were trained to become home health aides. So we were training from within the workforce, promoting, and then they needed to backfill for more entry-level positions. But the preceptor course was really instrumental in having on board those new home health aides, into the job, to have them shadow them, and to be able to kind of work through some of the issues that were difficult. Evaluation. So here's what actually came out of it. Pre-post test scores for their home health aid exam averaged 20% gains each person across the board. Chronic care management was developed and taught by faculty in the nursing department at Springfield Tech Community College, and so that it was very much, competency-based, and the exam showed there was an average gain of 14% from pre to post-test training. In terms of self-evaluation, 20% increase in job satisfaction across the board, which I think we know is pretty much linked to retention, satisfaction and retention. There was a 50% increase in the ability to notice patient changes in their health status requiring immediate attention. That was a result of the chronic care management piece, and that was the piece that we really wanted to address very much. And then a 60% increase in understanding of different cultural practices and behaviors in patient care. Those are some pretty substantial differences. There were some wonderful testimonies. We had lots to celebrate. And just want to mention that when we finished with our time in the simulation lab. So everything that they had learned up to that point was cumulative and played out in scenarios in simulation. And again, that was all videotaped and debriefed right during the class. So it was a really rich learning situation.
I'm hoping I can smile as much as Sharon. I don't know if you could see her watching the slides on the computer. She just had this biggest grin on her face. It was beautiful. We should all feel so passionate and excited about what we're doing. My name's Christy Johnston, and I work for Premier Home Health Care Services, and I appreciate the opportunity to speak today and talk a little bit about one of the programs that we've implemented to address workforce issues and transition with this ever-evolving healthcare system. A little bit about Premier. We are a multi-state agency. We operate in 7 different states, including Massachusetts. Our corporate offices have been in New York since 1992, and we I said at 7 different states. We're what we call in New York a licensed agency, a home care services agency. Other states, private duty and home aid services, a variety of different names for those types of services, but that is our origins. We are also a care management entity in 2 states. In New York, we care manage about 8,000 members' lives for our managed long-term care programs, health plans, Medicaid managed care programs. And in the state of Illinois, in the Chicago area, we do care coordination for about 14,000 participants in a program that runs through the Illinois Department on Aging. We service on a monthly basis about 34,000 people, a combination of care management and about 9,000 aid level services. And we're also involved in nursing assessments, both RN and NP assessments in New York and other markets, doing health risk assessments. Our agency offices range from, in the New York City area, thousands of aides in one particular branch to about 50 aides in our Fall River branch. So we span a lot of different areas. The slide here talks a little bit, and I think it's always helpful to set the context of why we have implemented the program we're going to flip to on the next slide, called real-time data. But as an organization, as many of you are experiencing and have experienced, this evolving healthcare system where we're dealing with this new tension of doing more and more with less and less. The expectations are increasing and are greater, looking toward outcomes, how to enter into value-based payment arrangements, looking at this evolving demographics where we have a graying of the nation. We need more workforce to be able to deal with an increasing demand for services. So you have this perfect storm of all these things swirling around. And in different markets, we've had really aggressive changes to how healthcare is delivered. In our New York market, We were one of the first states that was really pushing our Medicaid long-term care service programs into managed care in the early 2000s, and in 2012 it was mandatory enrollment, so we pushed into that market and learned to deal with managed care organizations, looking at quality measures, incentive-based outcomes, and then mandatory value-based payment arrangements. So we knew we needed to change. We needed to look at things differently. But how do you change when you're trying to do more with less? So the discussion internally was very much, what are our greatest assets? What do we do? What do we do well? We have home health aides. Home health aides, I think from an agency perspective, we talk about them as the greatest gift for people to be able to stay at home. The connections made with aides that are in the home are phenomenal and cannot be overstated. But we don't value them for all that they can do. So that was our impetus in kind of talking internally about what do we do? How do we bring our home health aides more into our interdisciplinary team in the agency? How do we make sure they're working collaboratively with our coordinators/schedulers, our field nurse supervisors, our administrations, our operations? And what do they bring to the table? Well, they're touching the member, the client, the patient every single day. They have access to that person. They are the ones that really can impact the outcomes of what's happening in the home. And they have access to data. They have access to information that nurses don't have regularly, that care managers don't have regularly. Aides are in the home and they have access to that information. So we took that, we said, how are we going to leverage and really invest in our greatest assets? And needing to do more with less, so let's do more with what we have. We are in about $3.5 million at risk in value-based payment arrangements with health plans. So the need to really look at how do we access data and be able to implement timely interventions to ensure that being at risk, we're on the upside. We would like the shared savings. We don't want to be at risk and lose money in this process. $3.5 million is a lot for any organization, large or small. So, real-time data, RTD real-time data. So this program that we implemented and really started rolling out in 2016 is a three-pronged approach. It is intended to take data that's transmitted by the aide from the home setting and bring it back into our office to create actionable data to implement timely interventions, to prevent avoidable hospitalizations, to improve quality outcome scores for the plans. And it starts with a comprehensive training platform, which we call Observe, Ask, and Report. And this is a training program that we have developed in-house and focuses on 4 different modules. They're 4 hours in length each. We train our entire LICSA, our licensed agency IDT on this. So we are training our aides, our coordinators, our nurses, our operations, our administrative staff, our management staff on the same curriculum, which varies slightly depending on what it is, and finding that you really need to train everybody on the same thing. So you have the aide who's observing something about a particular quality measure. They're asking their member what probative questions to try and figure out how they can intervene in a greater manner, or things going okay, and what to report back. Well, we want to make sure the coordinator knows why they're reporting something back, and whether or not they need to contact the nurse, and what the nurse needs to do with that information. So the training platform, or one, focused on quality measures that our health plans that we were contracting with were being measured on. UTIs, loneliness and depression, falls, avoidable hospitalizations. We then developed our second module, which was potentially avoidable hospitalization diagnoses that were being measured on with certain health plans. And we apply that same Observe, Ask, Report training format to those different diagnoses. We train them, and I'll talk a little bit more about the technology component in the next one, but they're trained on that, what the IDT model looks like. So all of these are modules assume that our home health aides, in addition to their basic training, in addition to the in-services that they receive all year long, can understand and need to understand what the changes are in the healthcare system. They can understand what the triple aim is. if they understand that, they then understand how they are the ones that can impact quality measures, how they, as an aide in the home, can impact the scores of a health plan, how they impact reducing costs and improving quality. And bringing them into that understanding helps them feel more empowered and feeling even better about what they're doing. They're not just taking care of someone, they're part of this big picture healthcare system change. We've moved on. This year we're training on OR 3 and 4. OR 3 is social determinants of health, so it's looking at the 5 different criteria relative to social determinants. What can you observe about nutrition? Do they have the right things in the refrigerator? What do you need to ask them? Do they have access to the right type of grocery stores? How can you report back this person needs transportation because it's a food desert, we need to get that meals to them. Maybe they need Meals on Wheels. Social determinants of health was a little bit more complicated to put together because your workforce is likely dealing with a lot of social determinants of health themselves. So it was a sensitivity thought process for our in-office staff working on this. And OR 4 is behavioral health, certain chronic disease, different steps that members may take to improve their own health, smoking cessation, we've added in opioid issues, things like that. And OR 5 and 6, which will launch next year, will be about HEDIS measures on the Medicare side. So we're looking at those different measures that the Medicare Advantage plans are being scored on and how it ties into their star ratings, and it takes us into some prevention. Why does somebody need a mammogram, colonoscopies, different things like that. So at this point, we've trained 32,000 on these different modules. We have about 10,000 aides trained in OR 1 and OR 2, 5,000 or so in OR 4 and 5, and working to round that out before the end of the year and launching into the next. Our training happens in 6 different languages, including English. And we provide a supplemental resource for the aides to take into the home afterwards, a laminated cue card that have the observe, ask, report questions, so they have resources right in hand. And all that training takes us to the technology that we have utilized. So electronic visit verification is something that we've had in at least our New York market for many, many years. We use a telephony-based system, and we decided, let's get the data from the home. So let's have the aide at the end of their visits answer yes, no questions on the phone. They're pressing 1, they're pressing 2. And a positive alert on something triggers back into our data system to identify that there's a problem. Okay, there's a fall, or has your member been hospitalized within the last 48 hours? Are they having an increased problem with urinary incontinence? Those different types of things. A positive trigger allows us, through our what we call our PQIP unit, which is Premier Quality Incentive Program. They monitor that dashboard, they push it out to coordinators, and that process works through a workflow to make sure that if it's a positive trigger, we take action on it. If it's not a positive trigger, we figure out what's going on. Does there need to be some remedial education for that aide to understand that issue? And then the nurse can get involved if necessary, and we can alert the care manager at the health plan if they want to get involved. So it's really, our use of technology right now is really about collecting that data. And that data gives us the ability to monitor things and improve our quality measures, which gets to the funding part of things. So how is it working? We are incredibly excited to see very positive trends in our quality measures. It's good for us as an organization, it's good for the payer, and most of all, it's good for the member. You know, that means the quality of their services, whether it's sustaining or improving, is in a good place. And this chart looks at one of our plans that we work with in New York. One of our big challenges is getting the data. So this data actually comes from the New York State Department of Health. There's 6-month assessments that look at these different quality measures. And so this is outside data. But the data that we're collecting, in addition to being able to monitor what's going on, allows us to then target interventions. So we can target interventions for the member, we can target interventions as we see that aggregate data come in and say, wait a minute, we're having problems with falls, issues with that. So we can identify a falls training module. which I talked to Helen about that earlier, to be able to do remedial education on one particular aspect of what's going on. So the data becomes so incredibly important to be able to look at it from all sorts of perspectives, population, aggregation. So we're looking at, okay, well, there are these 5 zip codes in the Bronx and more people are going to the ED. What's going on? Well, let's look at it. There are no urgent care centers in that area. Well, we can't impact that directly, but we can let the plans know that these are some issues. Or a particular cultural population is refusing the flu vaccine. Well, let's look at what's going on in there and try to implement interventions. Challenges, because there are always challenges. Time to pull it all together, thinking it through, figuring out your internal resources to apply to it. Funding. We've been fortunate in New York that we've had some robust workforce funding streams that have come into play. So we've been able to train people at in large numbers and have reimbursement flowing. It's something we were investing in before that because of the VBP payoffs in the end. And then it's internal compliance, getting people to report the data, getting the office staff to push when they need to and reward when they can. We are an organization that is unionized in New York, so certainly there are conversations that are ongoing of how to reward the home health aides for the role they play in securing value-based payment savings and things like that. And that's something that I think we'll see more and more of, making sure that the entire workforce is rewarded for what they're doing. And our next step in technology is using online training platforms, trying to figure out the best way to leverage that. We have some Care Academy stuff that we've been looking at, which has been phenomenal. And so those will be the next steps in our technology pieces. Thank you.
Hi everyone, my name is Helen Addison. I'm the CEO and co-founder of Care Academy, and I loved how my fellow presenters started out sort of with the story and the intent behind training and technology, and how their organizations think about technology as part of the training ecosystem. So I'd be remiss if not starting out this by saying that I have been a home health aide. I think that it is, for us, it was very critical in the heart of Care Academy to think always from the perspective of the user. For us, that is starting with my own experience. Alongside that, I was a high school teacher, and often wondering, could we create alternate pathways for folks to get into the workforce, right? And so I was a high school teacher in Atlanta, Georgia, with a program called Teach for America. And often I'd walk into my classroom with my 14 to 16-year-olds and say, college, 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 college. But I also believe that we could do a much better job, like our country peers such as Germany and Finland, of figuring out ways of getting folks directly into the workforce and training. I think we, in this country, are missing a huge opportunity to bring in workers at all levels. I loved what was said, Maureen, you said it earlier, in terms of folks of a certain age getting into the workforce. I think throughout the entirety of someone entering the workforce from 18 on up, we have great opportunities to bring people into our industry. It's an exciting industry. And first and foremost, I get to sit on panels just like this, but sort of facing outward in the technology realm, where I say that I am excited about what we do in our industry because I believe this is the future of work, right? So we talk about future of work, we talk about displacement. This is the final frontier. Healthcare work is the final frontier of work where we need humans, we need human interaction and contact. And I believe that being a home health aide, looking at the entire continuum, is the opportunity to bring people into the final frontier of work. So when we position like that, I think that there's so much to get excited about, and that's what keeps us up at night and gets us excited at Care Academy. I have an amazing team that I work with. So alongside myself being a former home health aide, an educator, my co-founder is Dr. Madhuri Reddy. She works at Hebrew Senior Life as a practicing geriatrician still, and an assistant professor at Harvard Medical School. So we actually balance each other out. We are the odd couple that are sort of the best of both worlds in bringing sort of the mindset of how do we make education as accessible as possible? How do we get folks excited about being part of the workforce? At the same time, making sure that we're grounding to what my fellow panelists said, in outcomes, in driving outcomes, and how home health aides and workers within this industry can drive outcomes. So at Care Academy, we say that we are scaling the future of the direct care workforce. One of the things that we think about from a technological standpoint is accessibility for everyone involved and all the stakeholders, right? So for us, technology is how do we look at the caregiver? How do we make education and training as robust and accessible as possible? So we actually, to this day, within the Care Academy offices, we invite home health aides who come from across our ecosystem. We actually provide training in all 50 states. So we interview folks all the time and just understand what else are they using, right? How are they engaging in media? A lot of our caregivers are activating on YouTube. They're using Facebook. Raise your hand if you've been on Facebook or YouTube probably for the last 24 hours, right? That's exactly it, right? So if that is your media diet, why would we propose that we do anything else, right? So for us, it is about getting down to how you're utilizing, everything else in your ecosystem, your technological ecosystem, and going down to where the caregiver is and making it as accessible as possible. So the way that we built our training is we engaged in sort of building coursework as modularly as possible. So within our classes, it's an hour-long class in order to meet state certification and any of the compliance requirements, but we've built it out into 5 to 7 minute chunks. And what you can expect if you're taking classes within Care Academy is these are all video-based scenarios. So the idea is that in our dementia class, we're showing the caregiver, rather than telling, the correct and incorrect way to talk to a client who may have late-stage dementia, right? It's a totally new approach, but I know that same caregiver who is, probably a Haitian American is watching soap operas, is watching YouTube, right? So how do I make the content that we are engaging them with as accessible and as engaging as what they're already doing? So, and within that time frame, the average caregiver on our platform, so we've trained roughly over 60,000 caregivers to date on Care Academy. They're viewing in 15-minute increments, and that's great, right? So in those 15-minute increments, I think we can all take a lesson here is that caregivers aren't viewing things in their entirety. What we often found in interviewing caregivers is that they were watching our videos on their bus ride home, right? Or they were watching between clients. Or they were doing what I was doing actually with the advent of YouTube. And they're saying, I remember learning this skill in my initial certification class, and I want to come back to that. Let me go into Care Academy and take a look at that video one more time, right? So whether it's on our platform or anything else, I think we should always think about how we orient technology and accessibility of technology based on what folks are already doing anyway. So I don't think we're doing anything remarkable, quite honestly. I think we were just observing what caregivers were already doing. So that is the caregiver. For the other stakeholder, we believe first and foremost it's also the employers. So for us, employers are actually the customers of classes, and we said there's really a robust need to be able to manage all the caregivers who are going through training, and how do we build a robust platform to be able to do that? How do we help folks manage their time on the platform? So we built basically a robust tool for employers to be able to sort of set it and forget it. We want to make sure that Care Academy is an extension really of the team. So folks aren't spending their, teams were already stretched. How do we make the training as the platform as accessible as possible for admins and also sort of have a mindset of set it and forget it? So when agencies come to us, we've gotten down to the point that once they've told us the caregivers that they want to train, we curate all of the training elements around the compliance requirements as well as the individual needs of the caregiver as well as the patient. Those are absolutely key, I think, to building really robust training and helping those agencies say, I have to navigate sometimes between what the individual caregiver needs, what the compliance training requirements are. So we actually built out our technology to be an extension of the care team and help folks kind of set it and forget it. We also provide the reminders because we found often when we interviewed a lot of our customers, we spent so much time reminding about training and sort of keeping tabs on training. So all of those reporting tools are built in. Actually, if you'll go down to the next slide. So in terms of training the direct care workforce, a lot of the agencies that we encountered had manualized systems. So we're thinking about how do we make, how do we digitize some of the systems that the workforce is currently using to train. And we looked across all of the technologies that agencies typically use. Raise your hand if you are familiar with some of the logos on this page. Exactly, right? So again, same mindset of what we did with the caregivers. We thought about agencies, what are folks already using? How do we help folks streamline their time? So training is a lot easier as a concept, it can be much more personalized. So we actually work with a number of the providers here. So My CNA Jobs, Next Steps, Elia Care, Clear Care were actually announced earlier this year that we're the first education provider to partner with Clear Care, right? In its 10-year history. Why did we do that? Because a lot of the things that folks have mentioned today already, so the background checks of caregivers, what clients in the care plan of the end recipient of care, the patient or the client, we're all in these systems. So it's incumbent upon our system to talk to the other systems that home care agencies are using, right? And by doing so, we were saving folks time. So our first agencies who are utilizing some level of these integrations, as well as the opportunities to share some of the background behind the caregivers and manage this data, we're saving up to 60% of admin time. So they've gone effectively from 70 hours that's been cut within a month of managing all of this background information of the caregiver, managing training, reminding of training, all because we have this information from the other systems that they're already utilizing, right? So we want to take that on. We want to help folks become much more efficient because we note that as a result of all of these systems not talking to each other, we have, of course, 82% annual turnover and the $7 billion cost of just sort of wasted time. So how do we make everyone much more efficient? How do we engage caregivers and meet their needs exactly where they are? So as a result of that, because we're able to provide for this level of efficiency both on the administrator side and accessibility on the caregiver side, overall across all 60,000 caregivers, we have a 90% course completion rate, right? It's the idea, again, that our expectation of the caregiver is that you're engaged, you're coming in, you're viewing what you want when you want it, and then you're done, you've completed your training. So this 90% course completion rate has held steady for us over the last 3 years. It's been pretty awesome. So just to describe the way it works, we actually created another tool, and that was a result of talking to our agencies. So agencies said, I have a caregiver who may have worked with another agency very close at hand, and they said that they've taken trainings with the Red Cross, they've taken trainings with Relias, they've taken trainings with you all already, right? And so they're gonna come to me and give me their certificates, and then I have to sort of figure out how to manage all of this across all 50 or 100 caregivers. So we, as a result of hearing out what our customer needs were, created a portability standard. And that's actually something that I think should be inherent within our industry. If we're going to minimize cost and wasted time, we have to figure out how systems can increasingly talk to one another, right? So the idea behind the portability standard in our platform was that any training, I don't care if it's ours, oh, sorry, I get very, I'm Nigerian, so I do a lot of hand talking. I don't care if it's, our competitors' training, I don't care if it's the Red Cross, I don't care if, it shouldn't matter, right? How do we get that caregiver out to the client as fast as possible and make sure we can support them in doing so without worrying necessarily about the initial training if they already have proof of that? So we've created that portability standard as a way for agencies to manage all of the history of their caregivers and support over those records as needed so that that caregiver that is not sort of wasting time, because we noted that industry-wide, a caregiver is most likely to leave within the first 90 days, right? So we're always, it's the race against time to make sure that that caregiver is able to sort of port through. So in terms of recruiting and onboarding, we also announced that we worked out from continuing education, and now we offer, we actually started debating this in Massachusetts, but we offer an HHA credentialing. And so the way that works is that caregivers can access our system, get some of their content training asynchronously, so that's on their own. And then agencies now are able to provide that clinical-based training for the Massachusetts HHA credentialing. And so we have several providers within the state who are actually utilizing the system since we debuted it only 3 months ago, and have trained, I believe at this point, up to about 50 caregivers, new HHAs who may have been PCAs previously. They were working at Dunkin' Donuts. But the idea also that we can bring in new folks into this workforce is really exciting for us at Care Academy. And it's a perfect, it's a perfect demonstration also of the blended model training. The idea that you need in-person, but you also need in-person in a way that's very effective alongside online training. We absolutely believe that you can't have one without the other in a very effective system. And then, of course, retention. So we're a younger company. Most of our agencies have been with us for about a year and a half. So we're already starting to see some of that positive correlation between retention numbers of caregivers who've effectively gone through our programs because they're getting supports. The thing that we always joke about at Care Academy is that because employers are using our training, all of that positive attribution goes to the agencies and not to Care Academy. So often we have caregivers who will text us because we have a text messaging system that they can report into, or will email us in our support line and say, oh, this is so great, I'm so glad that X home care agency is using this. This is amazing that I get this support, and it actually has a positive attribution for a lot of those caregivers. So I also want to make note of this. Just as much as online training needs in-person training, you also need support systems built around that. For us, that's part and parcel of our success. I will actually attribute part of the fact that we have that 90% completion rate, not only to the engagement level of caregivers in our online training, but also to the fact that we have dedicated people supports, right, on the back end of all of this. We think that's absolutely necessary to having an effective technological program and rollout. So on behalf of our home care agencies, we actually make sure that there's round-the-clock people supports too of folks that are ready and at call for both caregivers as well as for administrators as well. So that's something that I always want to make note of in terms of providing any technological solution. So we've scaled nationwide. We are 500 plus agencies, 60,000 caregivers. A lot of the content that we have created is aligned across states, so we get a crosswalk. And we've also developed out a set of training programs as well. So the idea that not only is the direct care worker the future of healthcare, but we also believe that there's incentivization of the system to create specialists, right? So after I've been deemed an HHA, how can we create and build upon the skills of that caregiver? That's a best practice that PHI points to. That's something that we've made essentially technologically able on our platform, is building in a level of specialization that's inherent to training care workers. So you can go down. So this is actually something that we've created. So after a caregiver is, of course, an HHA, for us, we looked across some of the most common chronic diseases that are inherent to health plans that folks are looking at, right? The most inherent comorbidities. And for us, of course, we've created the programs effectively to meet those needs. So Alzheimer's and other dementias, hospice, end of life, nutrition and diabetes care, heart conditions and respiratory conditions. So these are our first set. Over the next couple of years, we're building in even more. And we realized too that, and this is from watching our agencies, and this is the fun of being in a sort of technology company, is that we watched our agencies actually deploy a version of this, and we're like, hey, look, we've created these wonderful tracks for you based on our content. You can go ahead and utilize it right away. And they said, that's great, but we want to create our own tracks, right? So we found that even though we have recommended upskilling, agencies were creating their own because they were hired from within. And so we gave the power back to the agencies to not only utilize our own recommended upskilling, but also to create their own upskilling as well. And that's been wonderful to watch. So these are recommended tracks, but we're also seeing agencies, and we're watching agencies, because I think that's the best form of data, is watching your customers interact with your platform and seeing how they come up with things. A lot of the things that we create at Care Academy are very customer driven, so it's really exciting to see. And so, for us, it's also thinking broad term too. I think that there's a way to attract people, and I think our other panelists also spoke very emphatically and passionately about this too, is creating opportunity. We have to talk about broader opportunities within home care. We know that there are a number of folks outside of agencies who may be accessing other opportunities to learn and to grow. And so these are sort of the long-term upskilling pathways that we've developed sort of on the national level. This isn't something that we've developed internally or we manage internally, but what we're seeing organically happen in many cases, where you may have a home health aide who may also be going to nursing school. This is actually also the track, it's worthwhile saying, that my own family took in many cases. They immigrated from Nigeria. So we are thinking about long-term, just sort of visioning out the future where we say that, being a home health aide is about upskilling within, and there's so many opportunities to grow, and this is an industry that can grow with you. So how do we create those opportunities? Those can be effectively made through partnerships. So for instance, we partner with Southern New Hampshire University, and we know that there's a number of folks actually who've called in and said, I am a home health aide, but I'm also in a nursing program at Southern New Hampshire or any of the other participating nursing schools. So we think a lot, and we implore folks in terms of thinking about technology to also think about real world partnerships they're building in order for their home health aides and direct care workers to grow as well. That's it. I'll stop talking. Thank you so much.
Anybody in the audience with questions for any of the panelists? Christy, I'd like to start with you. I was very impressed with the fact that you're bringing the direct care workers right into the managed care quality measures. How has that been working for you? Just talk a little bit more about that.
I think it's great. We have had very positive responses from our post-satisfaction surveys of the training and from the workforce about being able to learn about what's going on and bringing people into understanding what are these specific quality measures and how do you impact that. And I think this workforce, as I said before, is capable of learning and understanding what's going on, and the more that the entire team knows what is happening and why it's happening, then they're able to contribute in their own way to improve things. And as we can see with our quality measure improvement, that moving more specifically at looking at what managed care plans are looking for, we're able to improve those measures, which makes the plans happy because their risk scores improve, and it all flows with the financing of different things. And you can look at different product lines, because one quality measure may not be applicable to another organization. We're doing some work with PACE, and we've added on different trigger questions that drill into what PACE is interested in looking for.
Real quick, so that the system you developed sounds really neat. Is that, you mentioned, I think it's a phone-based system. Is that something that the kind of the tech behind it, is that an in-house system you developed, or was that someone you partnered with, like a company or group that has developed it for you?
So we, first on the type of technology we used, and we as an organization have tried different technology, handhelds, things that require hardware as well as data plans and things like that, which are a little bit tougher to finance. So we have to do EVV, we use a telephony-based system, so we made it simple, very simple, and built it off of that. We partner on the EVV side with the organization that does our back office functions and developed that piece, and then our dashboard that we use for real-time data is actually something we developed in-house.
So you had mentioned as one of your challenges internal compliance and offering rewards across the workforce. Can you talk about the types of rewards that you offer?
So it is something, I mean, like with any agency, we have your traditional let's feed folks after we do different things, let's incentivize people, and offices handle it differently. More broadly, the discussion of how do you reward your direct care workforce financially. We haven't quite gotten to that endpoint yet. There are ongoing discussions in different markets. I mean, certainly in Massachusetts, we all understand minimum wage increases and that type of thing. In the New York City market, we have something called worker wage parity, which is on top of our $15 minimum wage. So $19.09 is the number that our aides receive in wages and benefits. But you know, we've talked about how do you operationalize that? What does the cost? So first of all, we have to receive incentive dollars back, so there needs to be a funding stream. And then how do you make sure you're rewarding those who are actually compliant? So it would be some aspects of that, and probably ultimately in a bonus type structure based on the outcomes and being able to share in those types of savings, but only for those who are at a certain threshold of the clock in and clock out and answering trigger questions.
You would mention that you received data from the New York Department of Public Health and that this drives the training. Can you talk a little bit about that? I'm assuming you have like a data use agreement and what types of data you get and if it's aggregated.
Yeah. So in New York, which is what we based the initial training programs off of, our managed long-term care plans, which cover more personal care services than any state in the nation. There are specific quality measures that those MLTCs have to adhere to, and they change on an annual basis slightly. And so the data is collected with a standardized assessment tool at 6-month benchmarks. So that data goes to the Department of Health, and they push that data back out to the health plans, and we receive scorecards. Some plans, so we work with 20 different plans. Some are much more sophisticated, and we can access monthly scorecards, which is great because then we can monitor things on a real-time basis almost. And then others come quarterly, and then others don't come at all. Some of the data is lagged because it comes from hospitals. Avoidable hospitalization data is 9 months, so we're a year behind. So we keep our own internal data as well, but that's how we tend to receive that. And then in our conversations with other plans and accountable care organizations, we look to them and try and set standards when in a scope of work to be able to pull that data so we know what we're looking at.
Helen, can you speak in a little bit more detail about any challenges you may run into with your training in terms of linguistic issues or learning issues?
That's exactly, actually this is the thread of our conversation today. Oh, absolutely. So, Maureen, you were asking, what challenges do we run into in terms of linguistic, and the other was learning. Exactly. Yeah, absolutely. And so I'll talk about the linguistic first because that is the challenge that we internally have sort of gone back and forth about, right? And so I used to work as a specialist in ESL with Boston Public Schools before starting Care Academy. And so when we think about translation, so just to even base set with everyone, so our trainings currently are in English, right? And that includes the videos, the scenarios, and everything else. And so we've thought about, as we thought about the totality of the population, what are the best ways to translate? And we weren't very satisfied with what is currently in the market, right? Because for one, I not only believe in speaking several foreign languages and home languages. There's the language of clinical care, but then it goes even deeper, right? It's the language of caregiving, right? And then that has also regional specificity. So, for example, if you're even talking about Spanish, there are different ways to sort of, what would be the expectations of somebody who is a caregiver coming from the Dominican Republic versus Mexico. So we're internally thinking about that, but for us over the next year, we're talking to not only sort of linguistic experts, but also caregivers in practice in those languages to make sure that there's a check and balance between those set of folks. Realizing too that overall within the caregiving population, there are different literacy levels. So we actually we're on something called a 6th grade Lexile, specifically because we wanted to make sure across the board, no matter the reading level, whenever we're introducing something that has to be read, it's sort of at that level. How do we also do that in the languages that we're translating to? So we've taken an overall census of the caregivers that we've had on our platform, so close to 70,000, and said, what are the backgrounds of those caregivers? And then we're now in the midst of asking that internal to the home care agencies that we work with as well, and then prioritizing based on that the languages that we dub into. We prefer to dub as opposed to translate. So obviously you can tell that we've been thinking a lot about this, and we're nerding out on this right now, and how do we do this and do this well, even if the way to translate doesn't currently exist in the market. How do we take it up a notch, right? To your other point about different types of learners, I think that's where the importance and the emphasis has to be on showing rather than telling. So we, 80% of most of our classes are video based, right? And so we hire probably the 3rd largest employer of actors in the state of Massachusetts, right? Because we want folks to see what those scenarios look like. A lot of caregivers actually happen to attrition because they said that there was a very little knowledge of what to expect once they entered into the home space, especially for new caregivers. So that was actually the impetus of, let's show a difficult situation. Let's show when a dementia, client lashes out, right? And showing those important moments, and then also the physicality of the caregiver, the tone of the caregiver also matters, and I think that transcends any barriers to learning too. It's like, how do we show folks in those scenarios so that no matter where you're coming from, you can actually gain knowledge.
Sharon, I've got a question for you. You talk a lot, your program is based on collaboration. You're a collaboration between 2 community colleges, and then you collaborate with local home care agency employers for the training. Do you see that model replicated around the state with other community colleges? And is there much collaboration between community colleges across the system in terms of curriculum design, standardized curriculums, any progress in that you can see the community college network making going forward?
Well, I can speak for us. I can't speak for the rest of the state in terms of who is collaborating. I do know that Training and Workforce Options is a unique collaboration. We are the only community colleges that are collaborating in this fashion, which is that we share staff. The schools split the salaries of those of us who are in the program, and we're working on behalf of both colleges. We are pulling on faculty and staff from each college to teach, facilitate and teach the classes. We're using space and lab space on campus, on both campuses. So I think it is unique, and I don't know of any other schools that are replicating that model.
The question I have for Helen, though, is you had spoken about there was no cost to the caregiver, but you track the completion data. And so I'm wondering if the cost is sent back to the employer, with prospective new employers, are you able to share completion data of the caregivers for what the trainings they're taking with the new employers, or is there a challenge there?
Let me make sure I understand your question, Ann.
Yeah.
So you're asking, do the employers utilizing our platform, are they able to see completion data? Or?
So you have completion data on each one of the workers.
Yes.
The trainings.
Yeah.
My understanding is that's funded by the employer.
Yes.
There's no cost back to the caregiver.
Right.
If that caregiver were to leave and go to a new agency, is that completion data sent to the agency to verify training?
So there are a couple things that have to happen. There are a couple steps, even utilizing our technology. So that has to be, the agency has to be willing to accept, right? Even if we have the record of the caregiver, that's not a sort of an automatic port. Inherent within any system, even if the caregiver were to bring the completion information, the certificate, the agency ultimately has to accept, is this viable, right? And so often, even though we can port those records at the behest of the caregiver, or even if the agency and the caregiver have shared an understanding and we can port over those records, the agency still has to accept it as its own, right? Because quite often what's happening is that, you know, so for instance, I was just in California 7 hours ago, and one of the tricky things there is that, you know, they have a heavy auditing process, right? And so for our California agencies, they have to demonstrate and show even the physical certificate, even when we have the porting record as well. Does that answer your question? I just want to make sure.
Yeah, it does.
Okay.
It does.
Okay.
Yeah, just curious about that.
Yeah. Yeah, it's not as automatic, and we completely understand why. For us, it's just about facilitating the process, but we are not by any means going to, you know, on behalf of the agency, say yes, this works, right? You have to still approve that. Yeah.